Participants, I hope you have no doubts. If you have any doubts, you can clear it now during the trial session. Once the event starts, it will be difficult. Thank you.
Ragesh, please tilt your desktop screen.
Mm,
Yeah, thank you.
Okay, we'll start with the event. Hello. Good afternoon to all. Welcome to the final round of Dr. House, conducted as a part of Medmeet International Undergraduate Conference, hosted by the College Union 2020 of Government Medical College, Calicut. Myself, I am Tanya Nasser, final year MBBS student from Calicut Medical College, and I will be moderating this event for you. I would like to invite our respected quizmasters, Dr. Albin Justin from Calicut Medical College and Dr. Danish E, Assistant Professor of Department of General Medicine from Government Medical College, Calicut. Sir will be joining us shortly. So, out of 525 participants, we conducted three preliminary rounds, and today we present before you proudly our five finalists for the final round of Dr. House. Now, moving on to the general rules of the event. All participants, please note the forthcoming rounds will be interactive sessions where the contestants will engage discussions with our judges. Hence, an active and uninterrupted network is essential for smooth conduction of this event. We have in total 8 rounds, and generally we have two types of rounds are there, or two categories of rounds are there. We have direct rounds and bounds and pounds. In Bounds and Pounds, all participants are requested to have collection of 25 white papers or blank A4 size papers during the event. All are requested to keep the page turned to the opposite side so that the answer is not seen by other participants. The answer should be written in capitals, possibly with a sketch pen or a color marker so that it's clearly visible to your monitors as well as the quizmaster. Malpractices like changing the paper, browsing are strictly prohibited. The decision of the quizmaster will be final. The participants are advised to have an additional network supply other than mobile data connection as a backup for caution. We request all our participants to kindly cooperate for successful conduction of the event. So I hope we can start with the event. I hope all our participants are ready. All the best, dear participants. Since it's an online event, sorry for certain guidelines and strict restrictions. However, all your efforts are highly appreciated. So, all the best, dear participants. Quizmaster, you can take over. Thank you.
Hi friends, myself I'm Albin Justin, 2014 batch MBBS, Calicut Medical College. So I'll be the quizmaster for this Dr. House event. I thank College Union 2020 for this wonderful opportunity to like to host this quiz for you, and all these participants are all wonderful candidates. You have made into the final of this prestigious event. So first of all, congrats to all of you. We'll be hope we'll all have a very enjoyable session throughout this quiz. We'll there will be only 15 seconds for each question, so you need the quiz will go on finish off very easily. So the first set of 6 rounds, personally I will be conducting it individually, and the last 2 rounds we will be having one of the eminent professors from my college, Calicut Medical College, Dr. Danish E, who is Assistant Professor, Department of Medicine. He will be joining us for the last 2 rounds, and those rounds will be bonus rounds, and you can score really high marks in those 2 rounds. So hope all the we had a trial, so hope all participants are ready, and all the best to all of you. So can we start? Like myself, because personally I am talking to a screen, So it will be nice if you make the chat box active. When the participants are ready, you can all type an yes on the chat box, and so that we can move on. Five yeses and we move on.
So just a query. This size is okay, right?
Yeah. Okay. It's okay. Chandrashu, are you ready? Yes. I expect a yes from you. Yes. Okay. Okay, Soumya. Okay. So we will move on. Moderator, you're there?
Hello, yes, I'm here.
Monitors A, B, C, D, E. Monitor A.
Yes, sir.
Monitor B.
Yes, sir. Yes.
Monitor C.
Yes.
Monitor D.
Yes, ready.
Monitor D. Monitor E.
Yes, sir. Ready.
Monitor E. Okay. Presenter.
Yes, ready.
Yes. Okay. So we will start. So presenter, please present the first slide. Scorers.
Yes, sir, I'm here.
Okay. Second scorer, you there?
Yes.
Okay. Yes, Dr. House, it's your speed that's gonna matter. Okay, so see, maybe you will be having 15 seconds to diagnose and come to the right answer. And I sincerely believe that a physician should not only just diagnose the condition, but he should know how to proceed with it also. So you can also expect like questions like bonus questions like what is the management, what is the first line of treatment, what will you do immediately. Such questions are also possible. Okay, so I hope we'll all have a wonderful experience throughout this quiz. So moving without wasting much time, we'll move on to the quiz. Okay, presenter, please show the next slide. Okay, so the first round will be neonatology. You will be having 5 questions in the set. This will be a bounce and pounce round. Scorer, please see plus 10 to the person who tells the correct answer in his direct chance. If he makes it wrong, there is no negative for him. But if he makes it wrong and another person has counts and he scores, he gets 10 marks. If he makes it wrong, he'll lose minus 10 marks.
Okay, sir.
Okay. So I'm indeed honored to have one of my mentors, one of my sisters, who was twice the golden in during both her diploma and postgraduate course in Calicut Medical College. We have well, at present working as an assistant professor in the Srinaran Institute of Medical Science, who completed her BBS from Calicut Medical College and completed her DCH and post-graduation from Calicut Medical College. So I hope Manjusha Rajesh, I call her Manjusha Chethi. Hope Manjusha is here. Chethi?
Yeah, I am here. Hi, and best of luck to all the participants. Thank you for that kind introduction, Alvin. And best wishes to you too, Best Master.
Okay, so personally, this is my first experience in a online quiz stream, and there will be a lot of mistakes from my side. So I request everyone to like adjust to all these small flaws that I'm making, and we'll see. We'll have a very wonderful time. I assure you that. So. Hope the teams have been assessed to you. Is it right? Monterey. Team A, who is A?
Yes, sir.
Monterey. Who is your team A, who is A?
Chandra.
Chandrachur. Okay, Chandrachur, you are team A. Monte B, who is the team?
Soumyadipta, sir.
Soumyadipta, you are B. C, Monte C.
Ragesh.
Rakesh, you are C. D.
Meemansa is my candidate.
Meemansa. Okay. Meemansa, you are D. And E. Monterey.
Shivaraman is my one.
Shivaraman. Okay. So this is a bounce and pounce round. 15 seconds to diagnose. Presenter, do we have a timer here?
Yeah, not time on the screen.
Okay. Moderator, can you please check for the time?
Yes, sure. I'll keep it time.
Okay. Thank you. 15 seconds. Immediately after the question is displayed, 15 seconds will begin. And at the end of 15 seconds, all those candidates who are pouncing, you need to go according to the instructions as we have given before. And team A, you will need to tell the answer only after I prompt you. Okay.
1 minute.
Excuse me, sir. During the pounce, if you can get a warning at 10 seconds, that would be good.
But that is very hard, Chandrachur, because just 15 seconds and on 10 seconds, then interrupting on 10 seconds and then it will. So you need to write the answer fast and you need to show the paper, not the answer, the other side. 5 yeses and we move on. 5 yeses and we move on. Participants? Okay. Presenter, please go to the first question. This is for Team A, first question. Team A, please select your hyperlink. Team A, please select your hyperlink.
What do you mean by that? I mean, select the hyperlink.
Yes, what?
Hello, Team A.
What do you mean?
Sir, what exactly do you mean by select the hyperlink?
Hyperlink is you need to select one. You have 5 diagrams.
No,
here,
I can
right?
see the slides. I can see the slides.
Okay. So you need to choose one question. Hyperlinks have a number. You can choose a number.
Okay. I mean, out of the 5 options, I have to choose one, right?
Yes,
okay,
yes, exactly.
Okay, so I'll take option 4.
4. Time starts. A term baby with phenotypic with deep jaundice and abdominal distension on day 3. Normal bowel shadows. Blood investigations, height, total count, anemia, thrombocytopenia, conjugated hyperbilirubinemia. What is the most probable diagnosis? What is the mutation? Time up.
The time is up.
Monitors, all set. Monitors, please wait, Chandrachur. Monitors, all set.
Okay, so
Anybody is counting?
No,
Monitors,
nobody
anybody
is.
counting?
The monitor B and D, he has reported no.
Okay.
Monitor C. Hello, Monitor C, are you there?
Hello?
Okay, that's okay. Monitor C, is your teammate bouncing?
No.
Okay. So, Chandrachur, it's your chance.
okay, sir, is it Alagille syndrome and the mutation JAG1?
No, this. I'm sorry, Dr. Chandrachur. This is already a case of Down syndrome. So you cannot, this is not the syndrome that they're asking. It's already a child with Down syndrome, who is presenting with the following features. So can I tell the answer to Albin, or are you going to do that?
You can tell the answer, madam.
So this is a condition, this is a condition which is known as transient myeloproliferative disease of the newborn. It is the condition that is peculiar to Down syndrome, that is due to a GATA1 mutation gene in the future. In the older, as they become older, they are more prone to develop leukemia. And this is one condition that does not need any chemotherapy treatment in the newborn period. The abdominal distension is because of the organomegaly, and the deep jaundice, they can be hemolysis secondary to the abnormal proliferation, as well as because it's a Down syndrome, child may be having congenital hypothyroidism too. So these two features may be. So I hope I'm clear there. If there are no doubts, I'll hand it over to Dr. Albin.
Thank you. Hope this was clear. So this was a case of transient myeloproliferative disorder, and hope you know that you need to know that there just need to observe, whereas in intermediate risk you need to strongly consider very low dose cytarabine therapy, and in high risk low dose cytarabine therapy plus aggressive supportive care, need like exchange transfusion is required. So we will move on to Team B. Team B, your direct chance. Moderator, are you ready?
Yes.
Team B. Team B, are you ready?
Yes, sir.
Yes. Team B, you can choose a hyperlink.
2.
2. Time starts. A term newborn baby developed severe respiratory distress soon after birth. No history of any maternal infection, coronamnitis, or prolonged labor or meconium in labor. Mother had an uneventful antenatal history. Baby was put on CPAP. Continued to have severe distress. Bilateral ground gas opacity, non-expanded lung field. Diagnosis.
Time's up.
Time is up. Anybody
Time's up.
pouncing? Anybody pouncing? Yes. A is pouncing. A is pouncing. Okay. D is pouncing. Okay. A and D are pouncing.
Yeah.
Okay. I hand over to Dr. Manjusha.
Can we hear the answers first?
Team B. Team B.
Transient tachypnea of newborn.
The answers of the pouncers, please.
Team A, what was your answer? Team A, show monitor A. What was Team A's answer? Monitor A. What is Team A's answer?
HMD.
Team D has answered transient tachypnea of newborn.
Oh, yes,
Dr.
ma'am.
Manjusha?
Yeah, I can take over from here. So I'll just highlight some key points in this question. It's a term newborn. First point is this term. Severe respiratory distress soon after birth is the second key catch here. And the negative history tells you that it is unlikely to be a congenital pneumonia, nothing of an infection sort of. And it is not MAS, it's not meconium aspiration syndrome. I'm doing this way because I guess Albin wanted to do, give you more information on the various aspects than just going question answer, right, Albin? Yeah. And
exactly.
Yeah. And baby was, despite being on CPAP, despite being on CPAP, child is still showing respiratory distress, and despite being on CPAP giving pressures, it shows bilateral ground glass opacity and non-expanded lung phase. So the key point here is a term with non-expanded lung phase. Two conditions which can occur in a term with the features. HMD is a broad term. Hyaline membrane disease is a broad term which can include any cause. Whatever be the cause, it can. And hyaline membrane disease is an obsolete term now. It is no longer called hyaline membrane disease. It is called respiratory distress syndrome when it is in a newborn due to because of the immaturity of the newborn lung. And this is a condition where it is like a immature newborn, but it is not because baby is immature. It is a mature baby, but at the same time, the baby does not have surfactant enough to open the lungs. So either it is a problem with the quantity of the surfactant, which is seen in surfactant deficiencies. In there can be deficiency in the A, B, C, D protein, whatever, or the cassette proteins. So there can be a surfactant deficiency, or the surfactant may be there and it can be a surfactant dysfunction. The first surfactant is not acting at all. And one condition which is very closely related to this is the congenital alveolar proteinosis. So any of these three answers would have been right. The key points, it is not HMD. HMD, by HMD, I guess you mean RDS, respiratory distress syndrome, because it's a preterm. And the condition where a term baby will have a respiratory distress syndrome is when the mother is a diabetic. Mother is an overt diabetic or an uncontrolled GDM. The baby can have, a term baby can also have features of RDS. That is because the lung has not matured. Okay, that is the same reason you give steroids to such borderline children, and mothers with GDM or overt diabetic are prone to have, even if it is a 37-weeker or 38-weeker, they can have RDS-like syndromes. But this is not RDS because one, it is a term baby. Second, mother had no other comorbidities. And it is not an infection also, we told, no comorbidities. And it is giving an unexpanded lung. In a term baby, you expect some sort of expansion even after CPAP. If there is no expansion, that means there is no surfactant to expand the lung. So I hope I am clear there.
Yes, that was a wonderful explanation. Key
Hello,
point, one point where, yes.
No, you can. Okay, sorry to interrupt. Participants, kindly note that you hold your answers up till your names are called. Okay, kindly note that you hold your answers up till your names are called upon. Okay, thank you.
Thank you, moderator.
Sir,
Yes.
how will the marks be awarded in this?
Yes. It was a direct bounce.
I don't think.
Bounce.
Yeah, I'm sorry to interrupt, but HMD should not be given a consideration here because it's basically one learning point is HMD is no longer the word used. Okay, it is just a pathological description of whatever is happening. I think the quizmaster expected that particular term, right?
Yes, exactly. Okay. So team B gets 0. Team B gets 0, no negatives. And now team A and team D gets -10. Since they have pounced and they have gone wrong, they get -10. Scorer?
Yes, sir. The score is noted.
Okay. Team C, are you ready?
Yes, sir.
Presenter? Yes. Team C, kindly select your hyperlink.
Number 1.
Okay. 1. 2-day-old baby, poor feeding, fast breathing, tachycardia, tachypnea, crepitations bilaterally, S3 gallop, hepatomegaly, structurally normal heart. A bruit was heard when the stethoscope was kept on the scalp. Most probable diagnosis.
Time's up.
Yes. Monitors, anybody bouncing? Okay, team D has bounced. Okay. Monitor A? Okay,
No.
Thank you. Okay. Team C?
Pass.
Team C, okay, passing. Dr. Manjusha?
Okay, so here it is the what to tell. This is a baby who is presented with features of respiratory distress, poor feeding, that the baby is lethargic, and features of failure.
Excuse me.
Cardiac,
Excuse me. Somebody has pounced. So,
sorry.
Dr. Manjusha, can you see the can the pounce team D and team D has pounced. Team D, what was your pounce? Monitor D, what was team D's pounce?
Vein of Galen malformation.
That was a wonderful answer. Wonderful answer. Dr. Manjusha, please take over.
And I would like to ask, maybe not going to be marked, but still a question to the team that has pounced and got it right. Would you care to tell me what vessel is involved in the vein of Galen malformation?
Ma'am, it's the median prosencephalic vein.
Perfect, perfect. Very good. So basically, this is a baby. It's a baby who is presenting with features of failure, respiratory distress, as well as congestive cardiac failure. Congestive cardiac failure because the baby has tachycardia. Baby is tachypneic, possibly due to pulmonary edema, and bilateral basal crepitations. Though it is not, actually equal to congestive cardiac failure at your level, basal crepitations, tachycardia, tachypnea is equal to CCF. And baby has an S3 gallop and a hepatomegaly. So basically, it's a right-sided failure that is happening there. Okay, so there is a congestive cardiac failure in the baby. Because of that, the baby is not feeling well. So all know all the sucrose cycle and the head sweating that can happen. Okay, though it is a congestive cardiac failure, in a newborn with congestive cardiac failure, first diagnosis will be a congenital heart disease. So you go do an echo and you find that the heart is absolutely normal. The heart and the lungs absolutely normal. You have taken an X-ray, but then because to expect something else, the doctor has gone and auscultated the scalp from a bruit. That is what he's expecting there, and he's got it. So the bruit is because there is what is actually all these murmurs and bruits are basically the turbulence produced by blood flow. So vein of Galen malformation, as the team rightly said, is a AV malformation that can occur due to the persistence of the median prosencephalic vein. Okay, so the bruit is because of the turbulence of the blood flow there, and because it's a high cardiac output situation. Any AV malformations anywhere in the body, be it the vein of Galen malformation or a large hemangioma in the liver, a large AV malformation in the liver, or anywhere in the body, the baby can present with a normal heart with CCF. So when you get conditions like that, you have to look for AV malformations elsewhere. One part of your clinical examination will be to look for a bruit on the scalp, which is seen in vein of Galen. Look for a bruit on the liver if there is hepatomegaly, to look for any AV malformations there on the spleen. Okay, so these are the things that you look for when you get such a situation. Yeah, I think it's clear cut there, nothing more to discuss. And the treatment is surgical treatment.
Okay, so in this round, Team D gets, I think Mimamsa gets 10 points. The Pouncer gets 10 points. Team D, 10 points.
The score is noted.
Okay.
Sorry to
Team D,
interrupt.
direct question. Yes.
Samyaditya sir, your eyes are not visible.
Samyaditya, kindly make necessary arrangements for your monitor.
Could you just put your phone a little bit up? It's not yet visible. Could you just move a little bit backside then?
Behind.
Yeah, now it's
Yes.
perfect. Yeah, thanks.
Okay, Team D, you are ready? Kindly choose your hyperlink.
Yes, sir. I think I'll go with 5.
Presenter, 5. Moderator, timer. A term newborn baby on day 1 while doing routine examination, abnormal pulse rate, tachycardia, ECG, multiple atrial ectopics. Baby was admitted, evaluated for the cause. No abnormality detected after detailed cardiac evaluation. Ectopic subsided by itself. Simple examination of the mother clinches the diagnosis. What is the cause of atrial ectopics? Monitors, anybody bouncing? Time is up, time is up. Monitors, anybody is bouncing? Is anybody bouncing? Okay.
No, nobody's bouncing.
Okay. Team D, this is your direct question. Dr. Mandusha.
Ma'am, is it that mother had SLE?
I'm sorry there, but I guess your concept is all right. So I think it's not SLE here because the baby is presenting with tachycardia. SLE usually presents with congenital heart blocks. So you expect bradycardia in the baby there. So this is a condition where the mother, mother having a condition due to some immune-mediated responses. The baby is also getting the antibodies from the placenta, causing it to have an effect on the baby. So it's basically a Graves' disease in the mother, and the antibodies passing on to the baby via the placenta, and the baby also developing thyrotoxicosis. So that is why the tachycardia there. If you're just I guess you missed the tachycardia there. If it's bradycardia, of course, your answer might be right because SLE is one thing there. But atrial ectopics are not very common in congenital heart blocks. You get ventricular ectopics more often there. Atrial ectopics very common, not very common, common in children having neonatal thyrotoxicosis. And usually neonatal thyrotoxicosis are transient events. It's just because the antibodies are placentally received from their mother, and when the antibodies go off, almost it takes 2 to 3 months for the antibodies to go off, and it solves. If the baby is symptomatic, you can give symptomatic treatment in the form of beta blockers. If the baby has persistent tachycardia, you can, and irritability and all that, you have to go and start treating the child. You can give beta blockers. Usually, anti-thyroid treatment are not indicated in a child born to a mother with neonatal thyrotoxicosis, provided the baby does not have thyrotoxicosis on it. But if it's very severe, the baby is failing to thrive, because the metabolism is on the higher side, the baby can fail to thrive despite giving beta blockers. The symptoms of the baby is not getting controlled. If all those features come in, maybe you will have to start anti-thyroid drugs also there. Okay. So usually, and this is not a very common finding in neonatal thyrotoxicosis, but you can find it. Yes.
Okay. Thank you, Dr. Mandisha. Team E, are you ready? Please choose your hyperlink. Team E, please choose your hyperlink.
3.
Okay. Moderator. A term newborn was admitted for seizures on day 2. Hypocalcemia corrected with IV calcium. 3 days later, baby developed poor activity, poor feeding, decreased urine output. Baby was in hypertensive shock and cyanosis. Complete diagnosis. I repeat, complete diagnosis.
Time is up.
Time is up. Anybody bouncing? Monitors, anybody bouncing? Okay. Team E?
No, sir, I don't know the answer.
Okay. Dr. Mandusha?
So before I tell the answer here, I would just like you guys to, know the answer, but it's just that you have not thought of it, I guess. I'll just help you analyze this question, okay? This is a baby who presented with hypocalcemia and seizures. So probably the baby has hypocalcemic seizures. So just tell me a few of the reasons you know for hypocalcemia in a newborn baby. If the baby is, born all right, hypoxia is a feature, HIE or hypoxemic encephalopathy is a cause. Now, this is a normal baby, otherwise implied. So, can you tell me some reasons that you know for hypocalcemia in a newborn?
Ma'am, is it DiGeorge?
Yeah, you know the answer. It's DiGeorge syndrome. So it's a DiGeorge syndrome that hypocalcemia is a cliche. Even if you don't know the rest of it, DiGeorge. Okay. Next, the question is telling you the baby is again presented with poor acting for feeding, decreased urinary output. That means there is something wrong with the circulation of the baby. There is a decreased circulation of the baby. Okay. Hypotensive shock and cyanosis. Okay. Cyanosis, hypotensive shock. Two reasons. One, the baby might be having some features of sepsis, but the question does not tell you that it is a septic shock or so. The question does not tell you that. But in the setting of DiGeorge, which can be a probable diagnosis of hypocalcemic seizures. If the baby, earlier we saw congestive cardiac failure. That means your lungs are getting congested. It's a high output state. Here it is a low output state. The cardiac output is less. That is why the circulation is less. So, DiGeorge is always almost associated with a congenital heart disease. It can be a cyanotic as well as a cyanotic. It could be here, it's more likely to be a cyanotic heart disease for 2 reasons. One, cyanosis. Cyanosis also can be due to shock, and mostly because the child is presenting in shock, that means your left output is decreased. Left ventricular output is decreased. So either there is some obstruction there, or there is some problem with your systemic circulation, right? So there are some cyanotic heart diseases which are duct-dependent lesions. Hope you have heard of duct-dependent lesions. That is, your persistent ductus arteriosus is the one which is keeping the child alive. So it can be a duct-dependent pulmonary lesion or a duct-dependent systemic lesion. Pulmonary lesion duct-dependent means there is, if there is severe critical pulmonary stenosis, no blood is going into the pulmonary tree. So some blood has to go to the pulmonary tree for the child to live, right? So the PDA will be shunting blood from the aorta to the pulmonary. If it is a duct-dependent systemic circulation, there will be no blood going into the aorta, no or very less blood going into the aorta. So this PDA will carry blood from the pulmonary tree to the aorta. So depending on the condition, I'm not going to the details. So here it is a duct-dependent systemic condition where the baby has developed shock because the PDA has closed. So the time, day 2, by 48 hours, by 24 hours, functionally PDA closes. By 48 hours, usually in a term, PDA closes. So the full diagnosis here will be DiGeorge syndrome with hypoparathyroidism because there is hypocalcemia and seizures. And you can tell hypocalcemic seizures with a duct-dependent systemic circulation cyanotic congenital heart disease. I hope I'm clear there. So the whole point I would like to put here is, even though I guess the questions are really good because it, as Dr. Albin said, it's not just by hearting things. So you have to, because when you're given clinical scenarios, you have to analyze. There'll be some key points which are glitches there, which will help you make the diagnosis. So once you know DiGeorge, you can think of anything which is coming under DiGeorge. Hypocalcemia comes, hypoparathyroidism comes, heart disease comes. So that is how you link things there. Thank you. Thank you, Albin.
So, thank you, Dr. Manju. So, I hope that was a very wonderful explanation. So, I think neonatology is a bit tough for you guys, right? Sorry, this is a national quiz, and all of you are wonderful quizzers. So, we need something that you can take home. So that's why I have prepared this very tough. So okay. So there's a small surprise for you, Presenter. Next slide, please. Okay, Presenter, we have 5 more questions in the neonatology round, and mind you, all these are simple questions. Not that tough as compared to the first 5 sets. This set has been prepared so that you can answer this very easily. Although the first round was also easy, but still this one is a bit more easy. Okay, Team A, please use your hyperlink. So the explanations will be very less for this from this round. We will be cutting short the explanations. The supervisor will be only checking whether the answers are right or not, and the hints for the answers. Okay.
So I'll take option 7.
Option 7. Moderator.
Yes.
Term baby asphyxiated. Term baby and asphyxiated mechanical ventilation, unable to wean off. Polyhydramnios, decreased fetal movement. Simple bedside test was done on the mother, pointed to the diagnosis.
Time's up.
Time up.
Time up.
Anybody pouncing? B is pouncing. Okay. Okay. So is E pouncing? Monitor, is E pouncing? Monitor E. Is your teammate pouncing? No. Okay. Over to Dr. Manjusha. Team A, what is your answer?
Is it maternal diabetes mellitus leading to a macrosomia in the child and polyhydramnios?
Yeah, you are audible.
Hello, am I audible?
There are no pouncers, I guess. Are they?
No.
Yeah, so that's the wrong answer, Chandrachud. So Again, I think where you went wrong is you assumed that.
Hello, ma'am. Hello,
Yeah.
ma'am.
Yes.
I'm sorry. Sorry to interrupt. We
Okay,
have
yeah.
a bouncer.
Bouncer, sorry. I'm sorry.
Participant B has bounced.
Yeah, please go forward, participant B.
Participant D, please tell your answer.
B, I guess.
B.
B for bouncer.
Tracheoesophageal fistula.
I can't hear you. Can you please repeat that?
Ma'am, tracheoesophageal fistula.
I'm sorry, the answer is wrong. So, Chandrachur, I think you assumed that the baby has macrosomia. It has not been mentioned in the question that the baby has macrosomia. So that is one thing. And tracheoesophageal, I'll tell the answer first. I'm not going to the explanations as Alvin told. I'm sorry. So this is a case of a myotonic dystrophy. The bedside test that was done on the mother was a percussion myotonia. So it's a muscular disorder because the baby, a polyhydramnios, decreased fetal movement. It is not TEF. It is not tracheoesophageal fistula because tracheoesophageal fistula won't present with decreased movements. It is just polyhydramnios that will be there, and it won't be difficult to wean off ventilator. And the bedside test in their mother won't give any answer to your queries. So it is a myotonic dystrophy.
Thank you. Team B, kindly choose your hyperlink. Team B. Team B, are you there?
Yes, sir.
Yes. Kindly choose your hyperlink.
8.
8. Term baby, cyanosis at birth, ECG showed left axis deviation, diagnosis.
Time's up.
Time's up. Anybody pouncing? D is pouncing. A is pouncing. Okay. Okay. Team B, what is the answer? Over to Dr. Manjusha.
Hello, I can't hear the answer.
I don't know.
Okay, the bouncer's answers first.
D, what is the answer?
Team D, please tell your answer. Please display your A4 and tell your answer.
Let me interrupt. Sorry, excuse me.
Yes.
Is E bouncing? I can't.
Yes, I am bouncing.
I think you can just tell out your answers because I can't see.
Ma'am, it's VSD, ventricular septal defect.
Okay, the other
team.
And since it is, ma'am, I am yet to complete my answer. It's VSD with Eisenmengerization, is it?
Okay.
Okay,
the other team.
Okay, moving on to the other team.
Is it a transposition of great vessels?
Okay, other one.
Is it tricuspid atresia?
Yes, that's the right answer. It's a tricuspid atresia because it's a term baby. Terms in babies, usually you expect the right ventricle to be dominant there. But despite being a baby, the right ventricle is not dominant, left axis dominant. That means there is some problem with your right ventricle. So of the answers you told, tricuspid atresia is the only place where the right ventricle is not developed. That is why there are no right ventricular forces there. So it's tricuspid atresia. Dr. Shivaraman, he is giving the right answer.
Dr. Shivaraman gets 10 points, and the other teams which bounce get negative 10.
Yes, the score is noted.
Yes, okay.
Hello.
Yes.
Hello, Quizmaster. Sorry to interrupt. All participants, please note that once you are pouncing your answer, even though you tell your answer loudly, you're requested to show the paper so that the monitors can see what you have seen. You may read your answer loud, but still you're requested to show the paper. Okay, I hope you understand. Thank you.
Okay, team C.
Yes, sir. Number 6.
6. Moderator. Down syndrome, bilious vomit, not past meconium, conjugate hyperbilirubinemia. Diagnosis.
Time's up.
Okay, B pounced. Anybody else? E pounced. Okay, B and E have pounced. Team
Sir,
C.
shall I say? Sir,
Yes, yes. Tell the answer.
Ersprungs, this is.
Sprung. Okay.
Other answers, please.
Pouncers. Team B, please call out your answer. Team B.
Duodenal atresia.
Okay. Team E.
Biliary atresia.
Okay. Over to
Okay,
Dr.
I think I
Mandisha.
can give it to Soumya Dipta because it's basically an obstruction at the level of the beyond D2, beyond the ampulla of Vater. So duodenal atresia is a broad term, but still I can give it to you. It's basically annular pancreas or duodenal atresia beyond D2 because there is bilious vomiting. So it is not above D2 because it is not above the ampulla of Vater, it is below the ampulla of Vater, one thing. In conjugated hyperbilirubinemia because the bile ducts, there is an obstruction to the common bile duct. Okay. So annular pancreas, duodenal atresia, duodenal web, anything can be the answer.
Okay.
Duodenal atresia
Scorer.
beyond ampulla.
Scorer.
I would like to hear the score, sir.
+10 to
Soumya
Dipta. Soumya Dipta is team. Soumya Dipta is team B. Okay. Soumya Dipta gets +10. And
Shivaram.
Team E gets -10. Team E gets -10.
Okay, that's noted.
Okay. Team D, your direct question.
Yes, sir. I think I'll go with 9.
9. Presenter. Term baby, unilateral facial palsy, day 1. Now, abdominal pinna, iris coloboma. Nurse was not able to put a NG tube prior to the X-ray diagnosis.
Time's up.
Time's up.
Is
B
it
is
Vector?
bouncing. Wait. Please
Sorry,
wait,
I'm so
please
sorry.
wait. It's okay. B is bouncing. C not bouncing. Okay. So I hope B is bouncing. Okay. Over to Dr. Mandisha.
Can I have the answer, please? Imansa?
Ma'am, is it Vactal syndrome?
And the Pouncer's
Okay.
answer?
Pouncer.
Ma'am, Charles syndrome.
Yeah, I would have to give to Soumya Dipta. It's Charge syndrome. It is choanal atresia that is there. That is why the nurse is not able to put in an NG. Coloboma iris, the ear and eye defects, and facial palsy, which is part of the syndrome. So there are other genitourinary and other malformations as well. It's not Vactral because choanal atresia is not a part of Vactral.
Ma'am, but tracheoesophageal fistula, that way also the nurse won't be able to put an NG tube.
They can put a NG tube, but it's just that it will remain coiled. It will not reach the stomach. You will have no problem in putting an NG tube. Only that NG tube will not be in the stomach. It will be just coiled in the upper part of the blind end of the esophagus. He was not able to put an NG tube because there was an obstruction there, choanal atresia. And it is unilateral choanal atresia that is there. Otherwise, the baby would have been silenced.
Okay, ma'am.
Okay. Team E, direct hyperlink. Team E, are you ready?
Yes, sir.
Okay, hyperlink 10. Moderator, time. Term baby, 4.5 kilogram. GDM mother, tachycardia, tachypnea, prolonged CFT, systolic murmur. Diagnosis.
Time's up.
Anybody pouncing? Okay, B and D have pounced. Okay, E, what is your answer?
So
Dr.
transposition
Manjusha?
of red arteries.
The
TGA.
other answers, please. Other answers, please.
Team D, what is your answer? Team D for dog.
Yes, sir, it's the same transposition of great vessels.
Okay. Team B.
BHD.
Okay.
So all the answers are wrong. It is not a TGA because there is no cyanosis which is mentioned here. Okay, there is no cyanosis which is mentioned, and TGA usually does not present with what to tell. This is not the presentation of TGA. Usually the patient presents with cyanosis and all that. That's why it's not TGA. It's not VSD because VSD usually does not become symptomatic in the immediate newborn period unless it is almost like a single ventricle sort of. Again, if it's a single ventricle sort of, there'll be some amount of cyanosis. So this is what is peculiar to gestation diabetes. It's called asymmetric septal hypertrophy, or the severe form, which can be hypertrophic obstructive cardiomyopathy. HOCM can also be the answer here. Severe forms of ASH, not the midal forms, the severe forms of ASH or asymmetric septal hypertrophy. It presents something like HOCM only, and the answer can be HOCM also here. This murmur is because of the regurgitant murmur there. Prolonged CFT because left output, though the muscle is hypertrophic, there is the left ventricular output is decreased. And gestation diabetes is the clinch here.
Thank you, Dr. Manjusha. Team B and Team D gets negative 10.
So the score is noted.
Thank you. So we come to the end of round 1, I suppose. Okay, I hope that was a very informative round. I don't think I have seen any UG quizzes where we have neonatology as a round. Personally, I'm a pediatric aspirant, and that's why I chose this round. And I thank Dr. Manjusha for wonderfully rendering all the explanations to us and making it more informative. We move on to round 2. I hope you will be there.
With your permission, I am signing off. I have some more things to attend to. So thank you so much for including me, Alvin. And guys, he's a great person, one of the best CMC has ever seen. And I really hope you come into pediatrics soon. And best of luck to all the participants. Have happy quizzing. Take care. Stay safe. Bye.
Thank you, Dr. Manjusha. Thank you to have you here.
Okay. So, without any further delay, now the explanations will be less. We'll be moving on with the quiz as everything will be direct hit. So, the next round is new drugs. Okay, this is not bounce and pounce. Okay, I repeat, this is not bounce and pounce. You need not write the answers. Only team to whom the chance comes, he will get the chance to answer. Okay. Okay. So I hope the scorer has put the scores on the chat box. Okay. So team B. This is your chance. Team B. Direct question to you. Team B. You can select the hyperlink first. We'll move as B, C, D, E, A. Okay. Team B.
2.
2. 15 seconds.
Time's up.
Okay. Samedita, what is the answer that you know?
I have to tell the use or the action.
Okay. Actually, I forgot to tell you the rules. Actually, you have 2 parts for this question. One is mechanism of action, and the other one is diagnosis. But leave the mechanism of action. Tell me the diagnosis. For what condition is this approved?
Breast cancer.
I'm sorry. Answer, please. Okay. It is a new drug which is approved for hereditary angioneuritic edema, C1 esterase C1 esterase deficiency. Now it is a human monoclonal antibody which targets plasma kallikrein. Okay. Okay, so Lenalidomide, newly approved drug for C1 esterase deficiency. Okay. Team C.
One, sir.
Direct question. Direct question.
Number one.
Number one.
So shall I say the answer?
15 seconds.
Time's up.
Sir,
Okay.
it's a fifth generation cephalosporin.
Diagnosis.
Resistant
For which
UTI.
condition? Very good, very good, very good, very good. Excellent, excellent. Yes. Can you just tell me the mechanism of action, Rakesh?
No ideas.
It's okay, it's okay. It is actually it is Trojan horse mechanism. Trojan horse. Okay. It is the newly approved FDA drug for resistant UTI. Okay. MDR gram-negative bacteria. Okay.
So how much marks?
Cefiderocol. Plus 10, plus 10. Plus 10 to team
The score is
C.
noted.
Plus. Okay. Team D, direct question.
Yes, sir. I think I'll go with 5.
5. 15 seconds. Please wait for 15 seconds.
The time is up.
Okay, yes.
Sir, it's used for migraine.
Very good, very good. Yes, it is. It is the newly approved antibody, monoclonal antibody for headache, migraine. Yes. Okay, very good, very good. Plus 10 to team D. Plus 10. It is erunumab. Erunumab. It's a monoclonal antibody against CGRP given for the prophylaxis of migraine, headache. Okay, next. Team E.
Number 3, sir.
Number 3. It is staphynoquin.
Time is up.
So malaria
Okay.
prophylaxis.
Excellent, excellent, excellent. Plus 10 to team E.
The score has been noted.
Staphynoquin is the newly approved drug which provides radical cure for against Plasmodium vivax. Okay. Team A. Yes, you are left with round happening
Option
4.
4.
Okay, nusinersen.
The time is up.
Okay. Team A.
Pass.
Okay, please show the answer. I think the drug itself has the name itself. The name of the drug itself has the answer. It is Spinras. It is against spinal muscular atrophy (SMA). It is an antisense oligonucleotide. Recently FDA approved for SMA, spinal muscular atrophy. Okay. Thank you. Okay. So round 3. Okay. Dermatology. Round 3. Direct hit 15 seconds for the diagnosis. Not bounce and pounce. It will start with team C. Team C, please choose your hyperlink.
Number 2.
Okay, 2.
Time is up.
Answer, please.
Pass, sir.
Okay. Press enter. Yes, it is physiogenic pedal papules. Okay. Team D, your direct question. Team D.
So fifth.
Okay, 5. Happening 5. 15 seconds. Starts now. Please don't give the answer till 15 seconds are over.
Time's up.
Sir, is this leukoderma?
Can you elaborate a bit? Leukoderma.
Leukoderma.
Okay, I'll give you. Okay, it's okay. I'll give you. Okay. Answer, please. It is actually halo nevus, subtle nevus, or leukoderma acquisitum centrifugal. Okay. It is a hypermelanosis around the nevus. Okay. Team E. Your direct question. Team E.
Number 3, sir.
Number 3.
Time is up.
Yes.
Sir, is it asteatotic eczema?
You are close. No, it is not asteatotic eczema. It is Basic syndrome. Answer, please. It is acrokeratosis paraneoplastica. Okay. Team A.
Option 4.
4.
Time is up.
Time is up.
Hello?
Yes. Yes.
Paucibacillary leprosy.
You were close, but this is not. I need a diagnosis. What is this? What do you see here?
ENL.
It's actually. Okay. I can give you 5. I can give you 5 marks. Okay. I can give you 5. Half the marks. 5 marks. It's actually histoid leprosy. In patients with long-term dapsone therapy, you see this type. Okay. Okay. Lepra bacilli was very much visible. Okay. Very good. Very good. Next. Team B.
1.
Okay. Yes. I think other teammates would be wondering this should have been a pounds and pounds run after seeing this question. Answer.
Time's up.
Yes.
Erythema multiforme.
Oh, I'm extremely sorry. No. It is nothing but it is erythema gyratum. Repent. Answer key. Placenta. It is erythema gyratum repens. Okay. The classical image. I was afraid whether somebody would find it so easy. So on putting this question. because this is very classical, the classical image that you can see. Okay, it's okay. So never make it wrong for the next time. Okay, so we come to the end of round 3. So next we have anesthesia round. So this is like, I repeat, we have not seen anesthesia round in most of the quizzes. So you'll be getting plus 20 points for the diagnosis and 5 points for the bonus question. Okay? 20 points for the diagnosis and 5 points for the bonus question. Scorer?
Sir, is there a negative marking?
Yes, sir.
No. Team D, no negatives.
Oh.
Okay. Team 1. Team, I think this is round 4. Team D, this is your direct question.
Sir, I think I'll go with 5th.
28-year-old male, upper limb fracture, plans for immediate correction, induced with propofol, choline, given for intubation and maintained on isoflurane. Intra of sudden increase in EPCO2, tachycardia, sudden increase in core temperature. Diagnosis.
Time's up.
Team D.
Sir, it's malignant hypothermia.
Excellent. Okay. Okay, the bonus question for you, management.
Management.
Yes.
Sir, dantrolene.
Excellent. 25 points to.
Yes, sir. The score is noted.
Okay. This is malignant hypothermia. Okay. Team E. Direct question.
Number 1, sir.
Okay, 1.
Time is up.
Okay, what is this?
So is it some endotracheal tube for children?
I'm sorry, I can't give it to you. It is actually ISL. It is a supraglottic airway. Okay. What is the advantage? Can you just answer the bonus question at least? You don't get any point, but still, what is the advantage of supraglottic LMA over the classical LMA? Do you know, Team E?
No, sir.
Okay. Actually, it has another entry for gastric tube too. So, like, you can also introduce the Riles tube as well. You can do gastric suction also in this. Okay, this is a supraglottic LMA. Okay, very good attempts. Okay, Team A. Direct question to Team A.
Option 2.
Option 2.
Time is up.
Okay, what is your answer?
Is it Procele LMA?
What?
Procele LMA.
No, it's a no. Presenter? How to calculate appropriate size? So what should it be?
Pass.
It is an oral airway. Okay. How will you? It is also called as girdle pattern airway, where the size is calculated from the tip of the incisors to the ankle of mandible. Okay? Okay, next question. Okay, team D has asked for a 5-minute break after this round. Moderator, is
Yes,
that possible?
hello.
Is that possible? 5-minute break?
I'm afraid that's not possible because we have our next event starting at 6:30, so we should stop our live streaming. So a delay might actually discourage our further schedules. I'm sorry.
I'm sorry, team D. Like you can go do something immediately during this time. I think 3 more questions are left. Okay. Okay. I think the next question goes to team B.
4.
Okay, 4. 36-year-old female undergoing surgery for follicular carcinoma thyroid, hypothermia, tachycardia, fall in EtCO2 possibility.
Time is up.
Okay. Diagnosis.
Bronchospasm.
Oh, no. Actually, any surgery, any a surgery, it is like this. It has this risk. Hypothermia, just opposite to malignant hypothermia. It is nothing but this is air embolism. Okay. Answer, please. Okay. What is the immediate positioning? Do you know? Anyway, pulmonary embolism. No, it is a left lateral position. It is also called as Durance position. Durance maneuver. Okay. Okay. Team. What just happened? Okay. Next question. Team D, I suppose.
Team C.
Team C. Okay, Team C. You are left with question number
3.
5. 3. Okay, 3. Okay, 24-year-old primary elective LSCS. POD2, patient complaints of headache, front occipital, nose in upright position, ease and supine, no neck stiffness, no. Diagnosis.
The time is up.
Pass.
Okay. Oh, so, okay. Please show the answer. Okay, it is post-dural puncture headache. Team C, what would have been the management?
Epidural blood patch.
Yes, it is exactly epidural blood patch. Okay. Now, audience question. I think we don't have an audience here. So, okay. Any one of the team. What do you see here? What do you see here?
Sir, there's a vocal
Yes.
nodule.
No. What is the procedure? What is being shown here?
Is it video stroboscopy?
It's,
Okay.
Sir, it's
What is the
indirect.
procedure?
It's
Indirect.
laryngoscopy.
Yes, it is laryngoscopy. It is not indirect. It is laryngoscopy. Okay. What is the grading?
Sir, Cormack-Lehane.
Yes, Cormack-Lehane grading system. Yes, very good, very good. Okay. You don't get any points for that. Okay. We move on to the next round. Okay, psychiatry. So psychiatry is also, it is a bonus round. Okay. So because normally we don't have a quiz with a psychiatry in the normal round. So Here also you will get plus 25. Okay, 25 points, direct hit for the diagnosis, 25. Okay, team, I think this is the fifth round. Team E.
So number 5.
Number 5. He was a fictional German nobleman. There is a psychiatric disorder in his credit. Identify this person and name the disorder as per ICD. Do you want a clue?
The time is up.
Sir, is it Gotthard?
Okay. I'm afraid no. Okay, your chance is over. But still, if I will give the clue as gridiron abdomen, what would be the answer?
Gridiron.
Okay, it is factitious disorder, then it is Munchausen. The image was Munchausen. Yes. It is Warren Munchausen. This is Munchausen syndrome. Okay. Team A. Team A.
I'll take option 2.
Okay, option 2. A doctor was writing down notes while interviewing a lady with schizophrenia. Patient commented, "I can feel you writing on my abdomen. Please stop it." On clarification, patient reported that every time she saw the doctor noting down something in his case file, she felt it on her abdomen. Name the phenomenon. This one is easy.
Any hint?
Time is up.
Sorry, there is no hint. I was just asking him whether he needs a clue. This one is a very easy one. Okay, Prasanta, the answer please. Okay, this is actually functional hallucinations. Functional hallucinations. Okay. It's one area where like we see a lot of NEET questions. NEET PG questions are a lot of questions are asked. Functional hallucinations. Okay. So team A, team B. I think it's your chance, right? Team B.
3.
3. Okay. 6-year-old male on treatment for schizophrenia, ED, relatives history of fever, rigidity, confused behavior, sweating, tachycardia. Recent history of hiking psychotropics following worsening of the psychiatric symptoms. Diagnosis?
Can I answer now?
15 seconds. Yeah, okay, answer.
The time is up. You can answer.
Neuroleptic malignant syndrome.
Excellent diagnosis. Plus 25. Plus 25 points. Okay, I think this was team C. Right. This was team C, yeah. Okay, team D. Okay. Next question goes to team C.
Number 1.
26-year-old migrant construction worker, history of penis shrinking into his abdomen, making him progressively weak. External genitalia examination was normal. Diagnosis. I think this one is easy. You can give the answer.
At Kuru syndrome, sir.
Excellent. This is Koro syndrome. Plus 25.
So the score's been noted.
Okay, thank you. Next question to team D.
Yes, sir. Ready.
Okay, Coro syndrome, also called as genital retraction syndrome, where a person feels that his genital. Okay. Moving to the question. I was born in Park Davis Laboratories, pet of West. I have been to Vietnam War. I am a party animal and I am into nightclubs and dance bars. Some people call me the marmite of drugs. I can relieve your pain. I can make you unconscious. I can even make you psychotic. My new job is in the lift. The mood division of psychiatry, and I totally enjoy it. I think I should answer. No, I can't add that line. Do you want a
Time
clue?
is up.
Yes, sir, a clue. Or maybe I can answer.
Yes, you answer.
Sir, it's MDMA, amphetamine.
Okay, you could have gone with the clue. Anesthetists say I am dissociated.
Ketamine, sir.
Oh yes, okay, but I can't give you the marks for ketamine.
So half
But it
marks.
was a very good attempt. Sorry, I'm very sorry. That was a very obvious clue. That's why I stopped. Okay, clue. But as I was waiting whether you'll ask for the clue or not, but you didn't. You presented the answer. Okay. Okay. Audience question open for all participants. Okay. German book, autobiographical novel like Johann von Goethe. Many youngsters copied the protagonist's behavior or acts after reading this book. Later, a term used as a synonym for media-induced irritation effects of that particular behavior and act became popular after the protagonist's name. Name that term. Any participant who answers this, like, I can send you a diary milk silk to your address, if possible. Oh, the clue is on. Clue is anybody?
Blue whale game, sir.
Oh no, I'm sorry. Okay. Presented. It is Werther effect. The sorrows of young Werther, copycat suicide. Okay. I think. Okay. Next round is heliotropath. No bounce and pounds. Direct hit. I think this is sixth round, right?
Yes.
Okay. Tanya, can you please call the supervisor of the next round, next two rounds, CCG and the other round?
Yeah, sure.
Okay. So this is heliotropath round. Direct hit starting from team A. Team A, please choose your hyperlink.
1.
1. Relapsed DLBCL, card cell therapy, hypotension, fever, rash. Pulmonary edema after 1 day. What is the diagnosis? Now, CAR test chimeric antigen receptor. I hope you are familiar with it. Diffuse large B-cell lymphoma on chimeric antigen receptor cell therapy, hypotension, fever, rash, pulmonary edema. Diagnosis.
Can I answer now? Or-
No, the time is yet to end. Okay, you can answer. Time is up.
Okay.
Is it Trally?
I'm sorry, no, it is not. It is cytokine release syndrome. Okay. Okay. Next question, team B.
3.
3. 44-year-old male, past medical history of multiple myeloma, daily nocturnal fevers, chronic articular rash for 3 months, bilateral ankle swelling and pain for 1 month. I think this one is simple.
Time is up.
Yes.
Don't know.
I'm sorry. Now it is actually it is a rare syndrome, but this person should be like aware of this. It is the Schnitzler syndrome. Okay. It is a type of auto-inflammatory syndrome. Okay. Female thymus following hysterectomy, biadyphorectomy was done, microcytic hypochromic indices, prolonged APTT. On mixing, there were connections 0 hours and prolongation at 2 hours.
The time is up.
Okay.
Lad like it.
Oh, no, it is not because of admission deficiency. It is acquired hemophilia. Okay. In D?
Yes, sir, ready. I think I'll go with 5.
Okay, fine. 35-year-old female with 3 miscarriages in first trimester and 1 in second. No significant family history present. Mild increased menstrual bleeding and large ecchymotic patches on trivial trauma. No anatomical or chromosomal abnormalities. Biochemical parameters, endocrinology, serology workup normal, APLA negative. Hematological parameters including basic coagulation tests were normal. Diagnosis and the symbol test in hematology. Just give me the diagnosis, that's enough. The symbol test is another clue.
Sir, can I answer?
15 seconds, please wait.
Yes, sir.
The time is up.
Yes.
Sir, is it von Willebrand disease?
Oh, I'm afraid it's not. It's actually factor 13. Slot solubility test was the answer. Okay, factor 13 deficiency. Okay. We move on to the last question. Team E, you are left with
Number
4.
4.
Yes. Fifteen-year-old girl, headache, vomiting, 7 days post-trauma, no history of fever, seizure, drug history, neurological systemic symptoms, examinations normal. Mother gave me a history of umbilical stump bleeding at birth, prolonged bleeding with minor injuries, everything normal. This one should be simple.
So can I answer?
Time is up.
Yes.
The leukocyte adhesion defect.
No, it was again factor 13. Okay, that is why this factor 13 deficiency, you need to be very much clear with it. Factor 13 deficiency is a very important question, very frequently asked for many quizzes, anatopath quizzes. Every quiz you will have one factor 13 deficiency question. And these questions, so I think this is it, right? Yes. Okay. Yes, factor 13 deficiency. So so we come to the end of 6 rounds actually. So I need to like our supervisor will be joining us soon. Moderator, did you get him on phone?
Yes, he'll be joining us.
Okay. The next 2 rounds will be bonus rounds actually. So our supervisor, Dr. Danisha, will be joining us. So I need to like actually thank a couple of people before this. So the first round neonatology, actually I took the help of the neonatology head of the department from my college. He is Dr. Mohandas Nair sir. and Dr. Nabil Faisal, who completed his senior residency from our college itself. They helped me to prepare those questions, neonatology questions. Then psychiatric questions. I had help from Dr. Arati, who is a senior resident in the Department of Psychiatry, and Dr. Smita, CA, Dr. Smita Cheruli Raipan. She's the Assistant Professor, Department of Psychiatry, completed her Child and Adolescent Psychiatry degree from Nimhand. She's a very beautiful psychiatrist, a very wonderful human being. Then all the questions of hematopath was made by the AIMS Delhi hematopath resident, Dr. Reema. She was the gold medalist in pathology from our college itself. Questions from dermatology was made by Dr. Ruvino Tonio. So Ruvino, she's currently the final year dermatology resident from our college. And anesthesia, the rounds were when I asked her to, it was prepared by Dr. Tanya. Not the Tanya Dasar, the moderator that we have. She's also both are wonderful human beings, I should say. These questions were prepared by Dr. Tanya. She is senior resident from the Department of Anesthesia. She's a very good anesthetist, I should say. Personally, I have a brother-like person who is there in anesthesia, is Dr. Anish, and both of them are very close to me. So I think the supervisor has joined.
Yeah.
Okay, so
Dr.
Sora, I think
we
Sora
have
is-
Dr. Danish sir with us.
Okay, I think Sora, Dr. Danish sir. Sir, are you there, sir?
Can I announce the scores?
Yes.
Okay.
Sir,
So,
please unmute yourself, sir.
So, dear participants, at the end of round 6, the total scores are: for team A, the score is minus 15, 1-5. For team B, the score is 25. For team C, it is 35. And for team D, it is 25. Team E, it is 10. So here we have team C in leading position. We have 2 more rounds. So all the best, dear participants.
Okay, so it's indeed an honor for me to introduce my mentor, my teacher, Dr. Danish sir. He's an assistant professor from the Department of Medicine. He just judged the second session of the case presentation event, and now he is back with the bang for a wonderful learning session for all of us. So we have 40 minutes left. We'll go very fast. Actually, he's a person who explains the whole cardiology very beautifully, but we don't have enough time. But still, I think he'll just give us with the glimpses of the cardiology, that the important points that we should note. And I should say, all these questions in the next 2 bonus rounds were like I prepared some questions, and he actually changed a lot. He changed those questions. He asked me to change, so that you all will learn. You all will have a very good learning experience with this quiz. So we move on to the ECG round. With your permission, Dr. Danish sir. Sir, can you please unmute yourself, sir? Danish sir, can you please unmute yourself?
Hello, Danish sir. Am I audible? Can you please unmute yourself? Your audio is off.
Okay, fine. Okay. Thank you, Alvin, for your nice words. Actually, I am a little bit surprised, and I am not at all prepared after 2 sessions. Now I am again back. So we will see what I will do my level best. Okay.
Okay.
So
with your permission.
Okay, you can start now. No?
So with your permission, we'll move on to the ECG round. This is a bonus round, ECG round.
Okay.
Okay. So if you get the diagnosis correct, you will get plus 20. And the bonus question that he asked, if you get it correct, you will get plus 10. Scorer, is that clear?
Yes, sir, it's clear.
Yes. Okay. Participants, are you ready? 5 yeses and we will move on.
So do we have bounce and bounce in this?
Yes, bounce and bounce. Yes, bounce and bounce. Okay.
So there is negative for
5
bounce,
years.
right?
Yeah, obviously, but the negative for pounds is only minus 10. Okay. You'll get minus 10, not minus 30. Scorer, is that okay?
Yeah, it's fine.
Okay. So if you are totally correct, you get 30 points. If you are wrong, you get minus 10 if you are bouncing. Okay. Monitor A, B, C, D, E, are you all set?
Hello.
Yes.
Hello. Sorry to interrupt, but there is a slight echo issue. Daniel sir, it
Yeah.
would be kind enough if you were using earphone. There is an echo.
Okay, fine. Yeah.
Thank you, sir.
Do you want me to unmute the mic?
Sir, either you can use an earphone or you can keep it mute when not necessary.
Okay, fine.
Thank you, sir.
Okay. Team A. Yes, Monica, do you have anything to say? Monterey?
No, sir. No, sir. Nothing.
Okay. Okay. Team A. All participants ready with the papers? Moderator ready with the timer? All monitors all set? Scorer ready?
Option 2.
And okay, to present it, option 2. 15 seconds. Please don't call out the answer. Okay. B has bounced. Daniel, please.
Okay, do you want me to give clues?
Yes, sir.
Okay, so this person presented with acute onset of seizure. So this patient presented with seizures. Casual.
Hello. Hello.
Moderator? Yes, understood.
Should I say the answer or sir was saying something?
No, he was saying the patient presented with acute onset seizures.
Acute? Could you repeat the last word? There's a lot of
Onset of
echo.
seizures.
This is from the ECG. I think it's a ventricular
Please
tachycardia.
wait.
Oh.
Moderator, is it time?
Yes, the time is up.
Time is up. Over to you, Daniel, sir.
Okay, it is a ventricular tachycardia. Okay, so shall I ask one more question to him? Okay, so what is the criteria that you use criteria?
It's like individual QR complexes will make diagnosis of VT more likely. Then, sir,
I'm afraid I don't think so. I will
know
give it
any
to you.
particular name of the criteria.
Yeah.
Give the criteria.
Okay, so shall I say it?
Pass. Yes.
Yes, sir. Yes.
Okay, so it's called Brugada criteria. Have you heard of it? Brugada criteria? You might have. What is Brugada syndrome? You might be knowing. No? Yeah. Brugada syndrome means it is a ST elevation and anterior leads with RBBB. Okay, so this is Brugada criteria.
Thank you, sir.
Okay.
So the person will be given 20 marks, right?
Yes, he is getting 20 plus 20.
Okay, fine.
Since he answered the diagnosis, all pauses are cancelled. Okay. Over to you, team B.
3.
Sorry, what was the question number?
3. Sir?
Okay. Do you want me to give the history to him?
Yes, sir.
Okay. This patient presented with acute onset of weakness of both upper limbs and lower limbs.
I'm afraid it's time up. Team B.
Time's up.
Answer. Anybody pounced? Anybody pounced? Wait. Anybody pounced? A has pounced. Okay. E. Monterey. No, okay. Only A has pounced. Okay. Your answer, please.
Hypokalemia.
Team B, your answer.
You should say what is the ECG finding?
ST segment depression and U wave.
Okay, you are seeing U waves. Fine. Okay, fine. So, okay, fine.
So the bonus question, please.
One more question. Okay, so what is the classical ECG finding in hypocalcemia?
Tall T waves.
No. There's a QT prolongation. You will get classical QT prolongation. Okay. Suppose you are getting a long QT, then you should think of hypocalcemia. Suppose it is short, then it is hypercalcemia. Okay, so
Thank you, sir.
Okay.
So B has been given 20 points.
Yes. Sir, please continue if you want to continue.
No, it's okay.
Oh, thank you, sir. Thank you. Sorry to interrupt, sir. With your permission, we move on to team C.
Okay.
Number 1, sir.
Presenter 1. So history, please.
Oh, this person, the say 40-year-old male who presented with acute onset of syncope to casualty. He's a diabetic also. Yes.
Moderator, is it time?
Yes, the time is up.
Okay.
Sir.
Team B. Okay, I think. One, please wait. Team. Okay. E, B, and A. E, B, and D has. E, B. All the other team has found. Okay. Team C. Yes. B diagnosis.
You should give your the correct diagnosis.
Is it inferior volume?
Only partially correct.
Sorry, we can't give it. Okay. Bouncers. Bouncers. Okay. Team E has bounced. Team E. Your answer? Team E. Your answer, please. Team E.
Inferior wall MI.
Okay. Team B.
Sir, it is inferior wall MI, but there is occlusion of right coronary artery
Okay.
with right ventricle wall involvement.
Okay. Team D. Okay, your team D. Team A.
Inferior wall MI.
Okay. Sir, I think we should give it to team B.
Okay. Actually, this is inferior wall MI with RVMI. You can see ST elevation in B4R. Okay.
Okay.
B4R, there is ST elevation. Okay, lead 2-3 AVF, there is ST elevation. So there is inferior wall with RV.
Sir, can team D get the bonus question, please, sir?
Okay, so suppose you are getting, okay, what is the ideal treatment when you are having a person with inferior wall MI and RVMI comes? What is the first treatment that you will give? Suppose a person is having hypotension.
Sir, we'll give fluids to this person.
Okay,
And
fine, good.
nitrates are contraindicated.
Okay, fine.
Okay, excellent. Okay, for a rate note, plus 30 to team B.
Okay, sir.
Okay, team D, your direct question.
Sir, I'll take 5.
Okay, 5. Presenter. Sir?
Okay, this is a young lady who presented with multiple joint pain and she had pedal edema and facial puffiness. Okay, and she had cola colored urine and she had decreased urine output. And suddenly she developed a syncopal episode and an ECG was taken and that showed this finding.
The time is up.
Team D.
Sir, this is a case of. So first of all, I can see tall tinted AVs, and secondly, there is AV block also.
Okay.
And
diagnosis.
Okay, diagnosis.
Sir, Mobitz type.
See, you told that there is tall tinted AVs.
Yes, sir. Hyperkalemia.
Okay, fine.
And sir, AV block with.
Okay. So is there a complete AV dissociation?
Then it is, sir, sorry, third degree AV block in that case.
Okay, so it's a hyperkalemia because of a renal failure. Most probably the lady is having a glomerulonephritis, renal failure with a hyperkalemia presenting as a syncopal episode. Okay. And
the bonus question, please.
Okay, so what is the renal tubular acidosis with hyperkalemia?
Sir, RTA type 4.
Oh, very good.
Very good. Okay, excellent diagnosis. You get plus 30 points.
It has been noted.
Okay. Team E, you are left with question number 4.
Yes,
Presenter. Sir?
Okay, this is a young male who presented with recurrent episodes of palpitation, weight loss and tremor. Okay, young male who presented with recurrent episodes of palpitation, weight loss and tremor. And he took an ECG and he showed this finding.
Team D has found. Team C has found. Team D has found. Okay, no more bounces. Team E.
Sorry. Atrial flutter.
Okay. What do you think of the scenario?
Sir, he's having flutter
Why
waves.
he should
So I'm saying flutter waves in the ECG.
No, the scenario, no, I gave you a scenario where a young male is coming with recurrent episodes of palpitation, tremor. That is your bonus question.
Okay, Timmy, we are really sorry. You should have really listened to the beautiful history that he has given. Okay, this is an atrial flutter, sir, please.
Okay, so it's a thyrotoxicosis. Okay, thyrotoxicosis, one of the ECG manifestation is atrial flutter with waving block. Okay, then the person may develop atrial fibrillation. So,
okay.
Sir,
Okay,
is there
that
some
was a-
amount of electrical alternance also?
pardon?
Electrical alternance.
No, it is not electrical. It is not electrical alternance. Electrical alternance means the QRS complex should be of different amplitude. Here the QRS is of same amplitude. Okay.
Okay, sir.
Okay. So all this, so I have put some weird ECGs, but sir actually insisted me to put this ECG so that you all will be sure of these ECGs whenever you get a case. Cases of the has we move to the last round. It's also the bonus round. You will get plus 20 for the diagnosis and plus 10 for the bonus question. Okay, this is also bounce and pound. Okay, we'll move with team E. E, D, C, D, A. In the other reverse order. Team E.
Yes, sir. Number 2.
Press enter. Please play.
Okay. This patient, do you want me to tell the history?
Yes,
sir. Yes.
Okay. So this person presented with acute onset of dyspnea to casualty. His ECG was normal, X-ray was normal, but echo showed this peculiar finding.
Time's up.
Sir, is it McConnell sign?
Yes, it's McConnell sign. That's a D-shaped heart. Okay, that is correct. Okay, so okay, do you want me to ask the next question? Okay, so I'm giving you a scenario. Okay, a young lady was developing recurrent episodes of dyspnea while she is brooming with a stick.
Sir,
can you hear?
Yes, sir.
Young lady, she developed dyspnea on brooming with a stick, or whenever she lies down, she assumes a lateral position. She used it to develop dyspnea. Her skin showed certain lentigines over the body. Okay. Cardiovascular system auscultation revealed a peculiar sound. and there was a mid-diastolic murmur also. What is your diagnosis? This lady had multiple joint pain and recurrent episodes of fever also. Yes.
So you can move on with the answers.
It's none other than left atrial myxoma. Okay. Left atrial myxoma, the presentation is like this. Trypopnea, platypnea, you will get a tumor blob, MDM. I have given most of the clues. I thought you will definitely say the answer. And even the lenticels over the body. Okay. It's okay.
Okay. Team E gets plus 20. Danny sir, will you be kind enough to use your headphones, sir?
Headphones? Okay. 1 minute.
Yes, sir.
Sorry, Albin, it's difficult because it's iPad Pro. There is no headset that is available along with this.
Oh, okay, sir. Okay. Sir, can you please mute whenever you are not speaking anything?
Okay, yeah, definitely.
Sure, sir. Thank you, sir. Team D, it is. Please self your hyperlink. Team D.
Sir, I'll take 5.
5. Okay. Sir. So can you give the history? Can you unmute yourself and give the history?
Okay, first let me read the ECG first, and I will ask question. Okay. So
it is our. Yeah, you got it.
Okay, fine. Yeah, got it. Just enlarge. So this was a lady who presented with recurrent episodes of palpitation. Then she developed recurrent episodes of cough and expectoration. And then she developed pedal edema. And because of this, an ECG was taken. Can you identify what the problem is? You can enlarge the ECG and for findings in lead 2, 3, ABF and V1.
Indeed, that is a very beautiful blue. Kindly make use of it.
Time is up. The time is up.
Sir, in this case, I can see that there is some kind of.
Pardon?
So there is some right axis deviation.
Yeah, definitely. Fine.
And sir, V1 also shows some positive waves. And
Okay.
in lead 2, I can see that P wave is large.
Okay,
So
fine.
it's P pulmonary likely.
And what about V1 and V2?
Sir, V1 shows. Okay, sir, it is right ventricular stroke.
Right ventricular?
Right ventricular hypertrophy and right bundle branch block.
Fine. Good. So what is the scenario? Now, based on the correlate with the history and analysis, so you are dealing with what type of a disorder? You are saying this lady is having a RV hypertrophy and right axis deviation, and the history is for a palpitation followed by a recurrent dyspnea, and so what it could be? An RV disease.
Sir, it could be pulmonary embolism also.
Pulmonary?
Embolism.
So do you think pulmonary embolism presents over a very long period like that?
No, sir, it doesn't.
Chronic pulmonary thromboembolism, I agree, but no. Think of a lady. Yeah.
Lady. Sir,
So I think we can move on to the
Yeah.
bounces.
Okay.
Has anyone pounced? No. Monitors? No. Okay. Sir, please explain.
So, okay, so this patient's ECG is showing actually RV hypertrophy because R by S is more than 1 in V1. So that indicates RV hypertrophy, and there is a RSR pattern in V1. That means RBBB, and there is a right axis deviation. So all these are indicative of a RV disease. And now if you see clearly, there is a notching of the QRS complex in lead 2 as well as in the, I think the AVF is there, but it's not that much clear. So that sign is called the crochet sign. I think you may not be able to make out it this, but you can say based on the history that an RV disease with the recurrent episodes of cough and expectoration, palpitation, it's a RV volume overload. So a pure RV volume overload condition is atrial septal defect, which is ostium secundum, which presents as RAD and RV hypertrophy and RBBP. Is it clear?
Thank you, sir.
Yes, sir.
Level, but no, the finally you didn't answer. And your bonus question? No bonus question for her?
No, sir. No.
Okay.
Sir, do I get any
Okay.
points for this for interpreting the ECG?
Pardon?
Do I get any points for interpreting the ECG?
Albin, do you give marks for interpreting ECG? She has interpreted,
I think
but no, she interpreted that. That is really good, and it
yes,
should be
I think she
appreciated.
deserves
Definitely,
10
she
points.
deserves she deserves a mark definitely because I need not want an undergraduate student to answer ASD by looking at ECG and all. So you can give
Yes,
her
sir.
marks, no problem, definitely.
Yes, sir. RAD and RBBB was
Yeah,
identified,
definitely she
sir.
did. So that is a really appreciable, and
Sure.
you are having enough knowledge also. Okay, but you have to
Give
clinically
10.
correlate. But you have to clinically correlate. Okay, that you will improve.
Yes,
But
sir.
it's really appreciable.
Thank you, sir.
Team B gets 10 points for this scorer.
Okay, yeah, definitely you can give.
Hello.
Yes, moderator.
Sorry to interrupt. The participant E has a doubt regarding score. Participant E, can you please unmute and ask it?
Yes, sir. Last round I got inferior wall MI right and atrial flutter right, but I was given only 10 marks.
Inferior wall MI is not right. You need to answer it as inferior wall MI with RV involvement. Classical RV involvement was there in the ECG V3R, so that's why you were not given marks. And what was the other doubt, please?
Yes, sir. That was the doubt. Will I get negative mark for that?
Yes, you wish.
Yes.
Since you okay. Inferior wall with RV was not answered, so you will get a negative 10. Okay. Okay. So next question, team C.
Number 1.
We'll move on a bit fast because we just have 10 minutes more. 1. Sir? No, I will give this. A 76-year-old woman with no previous history of cardiac disease, dyslipidemia, cardiovascular factor, and other medical conditions. Intermittent chest pain for 4 hours, compatible with angina. She denies previous symptoms of similar characteristics on admission. BP 105/60, heart rate 90, mild persistent pain. There was a systolic murmur in the left sternal border. Erase of this mesocardium. There was a systolic murmur, and this characteristic ECG finding was there. Okay, so and immediately she was on to some procedures, and these are the findings. Next. Okay, first let him diagnose the ECG.
You can concentrate on ECG and the clinical finding and with history, and you will get the diagnosis.
time is up.
Sir, it's Takutsubo Kadima.
Pardon? You mean
Takutsubo.
Takusubo cardiomyopathy is a scenario that occurs usually following stress. Suppose this lady is having some intense stress, or suppose a young ladies after death of the baby and all, they will be in intense stress. And in that scenario, the adrenaline will get released from the apical part of the heart, resulting in necrosis.
Sir,
Sir,
sorry to interrupt you, sir. Team D has found.
Okay.
Team D, what is your answer? Team D.
Sir, is it Brugada?
So it's not Brugada.
Okay.
So shall I continue?
Yes, sir. Yes, sir. Sure.
Okay. In that scenario, you will get Takusubo. Takusubo is otherwise called the apical ballooning syndrome, or otherwise called the stress cardiomyopathy. Okay. Takusubo is the name of the instrument that is used to what? Capture sepia. Okay. So fish. In that scenario, you will get giant T-wave inversions. Okay, but here it's an ST elevation. There is a QS pattern in V1, V2. Okay, that's called as the evolved underwall myocardial infarction. And in that scenario, this lady is having a murmur in the left sternal border is indicative of a ventricular septal rupture. And you can clearly see the BP as what? 90. And underwall MI is more commonly associated with VSR, and inferior wall MI is more commonly associated with mitral regurgitation. Suppose you are getting a pansystolic murmur like this in the left sternal border, you have got two DDs. One, it could be an ischemic MR of papillary muscle dysfunction, or it could be a pansystolic murmur of ventricular septal rupture. The mortality is 90% with VSR. Okay.
Thank you, sir. Thank you. Team, I think this is.
I would like to hear the marks, sir.
-10 for Team D.
Okay. Thank you.
Team D.
4.
4. Okay. Sir. Sir, please unmute yourself, sir.
Oh, sorry, sir. So, this is a scenario where a person was having certain findings. Okay, one of the finding is this thing. Okay, the first finding was that person was able to touch his nostril with the lips. Sorry, the tongue. He was able to touch the nostril with his tongue. Can you do that? No. He was able to do one more thing. That person was able to do a reverse namaste. See, we do give namaste like this, but that person was able to do namaste with reverse. And his skin was so lax. And that person had a BP of 160/60. And the cardiovascular system showed cardiomegaly and an early diastolic murmur. So, what is the scenario?
The time is up.
Marfan syndrome
Actually, it is not Marfan's. You won't get a blue
associated
screen.
with mitral valve prolapse.
No. Okay, others?
Sir, we have a pound.
Okay.
Candidate A.
Is it May Sadian, sir?
Which one?
Hello.
Yes. What is the answer?
Sir, is it Ehlers-Danlos syndrome associated with coarctation of aorta?
You mean Ehlers-Danlos with coarctation of aorta?
How did you pick up coarctation? And
Sir, because there is a huge difference between systolic and diastolic pressures in the limb, and there's a late diastolic murmur.
actually, what I have given is a wide pulse pressure and an early diastolic murmur. So that is indicative of what?
Oh, aortic regurgitation. Oh.
So his answer is only partially correct. It's only partially correct. So I will give you some more marks if you are able to say the name of the sign that no, the person is able to touch the nostril with the tongue. What is the name of the sign?
I don't know that.
That is called Gorlin sign. You know what is Gorlin formula?
I've heard of Gorlin syndrome, but not Gorlin formula.
Okay, so it's partially it is correct. So Albin, I don't know how to decide on the marks. Yeah.
Sir, he's wrong. It's negative, sir. Negative 10.
Okay.
The score given not
Down, sir. Okay.
Yeah, Tanya
Can we move on to the next question? Sir?
Okay. Yeah. This person, shall I say the question?
Yes, sir.
Okay, so this person got admitted to the casualty with history of acute dyspnea. And suddenly he developed a massive hemoptysis also. And he also had hematemesis. And the chest X-ray was this thing. And the BP, examination of the BP gave some clue to the diagnosis. This person also had intense chest pain. I think, do you want more clues? It's a very simple question.
Is it rupture of the aorta?
What do you call that?
Acute aortic dissection leading to aortic rupture and hemothorax.
Okay, yeah, that's it. Actually, this is an aortic dissection that is producing what? Lopsided pleural effusion, and again it can even erode or rupture into what? The bronchus, and it can even erode into the esophagus, and it can present with massive hematemesis.
So his bonus question, please.
Yeah. What is calcium sign?
So could you repeat that again?
What is calcium sign in radiology?
Calcium. Pass.
Okay. Anyone? And anyone else? Calcium sign means no. It is the classical radiological sign of aortic dissection, where even in aortic aneurysm rupture also the distance between the inner intimal calcification to that of the outer surface of aorta, if it is more than 10
millimeter.
Yeah, that is called as the calcium sign. Okay.
Thank you, sir. Thank you.
I hope I didn't ask any tough questions.
No, sir. No, sir. Okay, moderator.
Hello.
This is it.
Am I audible? Okay.
Yes.
So, dear participants, with that, I request all others to kindly mute your audios, please. Okay. So, dear participants, with that, we have come to the end of the scores are. For team A, the score is 10, score is 0. For team D, it is again 0. And for team A, we have 20 points. So that was the final round of Dr. House event. With that, we have come to an end. And Quizmaster, could you please announce the results? The scores are in the chat box.
Sir, can you please announce the results, sir? I can't see the scores in the chat box.
Alvin, you announce the result because I came only in the part of the session, so it's better. You have done much effort and all.
Hello.
So if the
Hello.
other person is, yeah.
Sir,
Interrupted time. Okay.
Sir, sorry to interrupt. What I announced now was a score of round 8 alone. We'll tally and give the total scores.
Yes, Dan, that's okay. Participants, please note the total scores have been calculated and will be put in the chat box and will be announced very soon. Can the participants, can you please tell something about your valuable opinions regarding the quiz? Team A.
Hello.
Yeah.
Sir, I didn't get what you said. The connection is very poor for some reason. There's a lot of echo.
Your opinion regarding the quiz.
Oh,
What
sir,
you felt?
I enjoyed the quiz very much. Some questions were a bit tough, much tougher than I expected actually, but I enjoyed it thoroughly and I learned a lot of new things. So it was a very good experience.
You are from which college?
Medical College, Kolkata.
Okay, so again, no, I also enjoyed participating with you, and I also I don't know uh, how you interrupted the way that we analyze things, but no, the way we teach is maybe something different from the teaching over there. Okay, so so here in undergraduate and all, no, how do you learn ECG and all?
Do you learn ECG in your college UG period?
Hello.
Yes. Do you learn ECG at your college?
Yes, sir, in clinical tutorials, but not of this level. We did
This
at
is what we
MIT.
call it as. This is what we call it as quiz, no?
Team B.
Nice time interacting with you.
Team B, do you have anything to say? Team B, C, D, E, anybody can unmute yourself and speak up.
So each and every round of this quiz was absolutely great. Starting from the prelims, then to the finals. Great.
Thank you.
Especially the ECG part.
Okay. Mimansa Jindal, no? You are from which place?
So UCMS Delhi.
Okay. So in Kerala, the academics is something different. Okay.
Yes.
So if anyone is interested, now you come to Calicut for our medicine department as postgraduate over here.
So definitely, sir, if I get an opportunity.
We welcome all of you to our college. This is college where you have got 250 students. It's a very good atmosphere over here. We do have very nice teacher-student relationships, and it will be very nice. And no, I have gone to different colleges as external examiner, and I have seen some students. So today, you know, we had some other session also. It was again really nice. So you, I hope you enjoyed.
Moderator, are the scores ready?
Hello?
Yes.
Yes, the scores are ready. So at the end of the 8 rounds, the scores are for team A, the point is 5. For team B, the point is 35. For team C, the point is again 35. For team D, it is 85. And for team E, it is 40.
Can we have that on the chat box, please?
Yes, I'll
Hello.
put it.
Yes, Soumya.
Sir, I have a doubt. In round 7, I got one correct, hyperkalemia, and didn't get any negatives. In round 7, I should get 20s, but it's written 10.
Scorer?
Hello?
Am I audible?
Yes.
He got 20 points correct for one question and minus 10 for one question, which was bounced. And that question was the same question, inferior wall MI. Hope I'm clear.
Soumya?
I didn't get the chance to answer.
But your name was given like...
You pounced.
Yes, I pounced, but I didn't get the chance to answer.
Team monitor A, he has...
Monta has given the answer.
His name was...
My answer was recorded.
But your name was there in the chat box.
I had pounced, but I didn't get the answer, didn't get the chance to answer.
Over to the monitor and moderator.
The pouncing was done. Like I had informed that he had pounced in the chat box.
I didn't get the chance to answer, so how can it be minus 10?
Okay. Please cancel the minus 10. Okay. Since it is a fault from our side, please cancel the minus 10.
Okay.
Moderator, is that okay?
Hello?
Moderator, is that okay?
Yeah,
Since it
that's
is a fault
fine.
Okay.
Scorer, can we have the scores of today and the score of the entire event in the chat box, please?
Soumya, we are sorry for the inconvenience that we had caused.
No, sir, it's okay. Thank you, sir.
The corrected scores will be put in the chat box now.
Scorer, are the scores ready? Okay. So the as far as today's session was concerned, here are the scores. Danisha, with your permission, can I please read out the scores?
Yes, go on.
So, yes. So here are the results of total results of today. Tanya, please do what is required. Thank you. So Team D comes to the first position with 85 points. Team B comes to the second position with 45 points. Team E with 40 points comes third. Team C with 35 points comes fourth. And Team A with 5 points comes fifth. That's it. Moderator?
So congratulations to the winners. And all are winners actually. There are certain days for each and everyone. So each and every day, failure is actually the success to the, this is the stepping stone to success now. So there may be some falls on each and every day. So it's okay. All of you are actually the winners.
So here are the final results. The winner of Dr. House is customer D, Team D, with 97 points. The first runner-up is Team B with 60 points. And the second runner-up is Team E with 51 points. Team C is the third runner-up and Team A is the fourth runner-up. Congratulations to all the winners. And thank you.
Hello.
Over to you.
Hello.
Yes, moderator, over to you.
Okay. Thank you. So with that, we have come to the end of the Dr. House competition. And yes, we have, this is a very tough competition. As I said in the beginning, we had 525 participants initially. From that, we shortlisted and presented before you proudly our 5 finalists for Dr. House. So in fact, all 5 of you are winners. So congratulations, first of all, to all participants. But since it's a competition, we have to pick, it was a tight competition. So finally, we have 3 winners in first, second, and third position. So in the first position, we have Team D, Me Mensa. And in the second position, we have Team B, that is Saumya Dipta. And in the third position, we have Team E, Shivaram. So that was the final results. And thank you all participants and congratulations to the winners. I hope all our dear participants had a wonderful time and a good learning process over here. So since it's an online event, sorry for the strict guidelines we followed and the restrictions. However, we highly appreciate all your efforts. So when we conclude the session, I would like to express my sincere gratitude to our quiz masters, Dr. Danish E., Assistant Professor from the Department of General Medicine, Government Medical College, Calicut. In spite of his busy schedule and attending 2 of our sessions in Medmeet today, sir made time for the Dr. House. So thank you so much, sir. I would also like to thank Dr. Alvin. Thank you, sir. I would also like to thank Dr. Alvin Justin, who is a graduate from Government Medical College, Calicut, for his kind presence. Also, I would like to express my sincere gratitude to Dr. Manjusha ma'am, who joined with us in the first round. Unfortunately, she had to leave after the first round. So thank you all for all your cooperation and making this event a great success. So with that, I hope we have come to the end and we can leave the meeting happily. Thank you.